Okay, so this is chapter 12, and we're going to be talking about disorders of hemostasis. So what is hemostasis? It is stopping bleeding, essentially. Okay, so the fancy definition of that is its purpose is to prevent blood from leaving the vascular compartment. Okay, well that makes sense. You have your cardiovascular system. It's supposed to be closed. Blood is supposed to move through the cardiovascular system. It's not supposed to get out. So a when some damage takes place where blood starts to leak out, that has to be blocked, and that's what we call hemostasis, or to stop the blood. Um, so you want blood to flow smoothly through the vessels, but you want it to clot when necessary. So that means that what you've got running through your blood vessels right now is sort of this ticking time bomb kind of thing, where it's at any moment in any part of your blood vessels, it could form a clot. And so we have activators that can activate the clots or activate clotting, and we have inhibitors that are usually turned on to prevent clotting from taking place. So you can kind of understand where some pathologies can occur when any of these things go wrong. Either you're going to have clotting where you don't want it, or you're not going to have clotting when you need it. Okay, so fortunately, usually this system works fairly well. Okay, so as I said, disorders when inappropriate clotting occurs or when the clotting that's supposed to take place is insufficient. Okay, so hemostasis is a combined effort that involves thrombocytes. So from now on, we're going to think of platelets. We've always heard the word platelets, or maybe we have, but that's more common than using the term thrombocytes. Well, we need to call them thrombocytes. Thrombo comes from, oh, I don't know, I think Greek, and it means clotting. So these are the cells for clotting. And these are made in the bone marrow, okay, with the rest of the blood cells. They're actually made from something called a megakaryocyte. So we also have, in addition to the platelets are going to aggregate, but we have other things that have to take place too. And that needs a lot of other molecules. Most are made in the liver, but these are plasma proteins. That means they exist in the plasma, but they're coagulation factors. So coagulation is going to be that process whereby the platelets aggregate, and then you have this fibrin mesh that forms over it. And that's kind of what we're going to talk about. We're going to go through all those steps of coagulation and clotting. Okay, and then we have another thing that's very important that almost seems, I don't want to say it's forgotten about, but the endothelium plays a pretty active role in clotting as well. So the endothelium, meaning those epithelial tissues that are the boundary or the inner surface of your blood vessels. So the blood vessel lining blocks platelet adhesion most of the time. So most of the time your endothelial cells, or your endothelium, the epithelial cells lining the blood vessels, are constantly producing factors that say don't clot here. And so a lot of times when those aren't working properly or something like that, then you could have some spontaneous clotting. But most of the time what happens is the epithelium will actually produce factors that say, okay, yes, damage has taken place. It's time to clot here. Okay, so platelets, so when we think of the term platelets, again, we're going to think of them as thrombocytes. Sites, of course, meaning cells. Um, they live 8 to 9 days in circulation, and there's a pretty good reason why they only live 8 to 9 days in circulation, and that's because they don't, kind of like red blood cells, except red blood cells last a lot longer, but platelets don't have a nucleus. They're just pieces broken off. So you can see here are these megakaryocytes. These are these cells that are made um, they again progress from the pluripotent and multipotent stem cells, and then they form these big cells, megakaryocytes, and these megakaryocytes just they're sitting in the bone marrow, and they just kind of protrude. Parts of these cells just kind of protrude into the blood vessel and then break off. And so you can see all these little bits that are breaking off here. And these are all platelets. Okay, so they're joining the blood vessels that we can see here, and then the platelets are these smaller pieces. Many of these are stored in the spleen. Okay, so Up to a third of the platelets at any one time are stored in the spleen. Now the spleen has that part where the blood vessels just sort of dissolve, and then you have this what's called red pulp, and the platelets will just kind of collect in that area. So an enlarged spleen may collect more platelets. If you don't have a spleen, well, I mean, initially you may have an increased platelet count because these platelets have to go somewhere, but then your body will adjust and you'll only make the number of platelets that you need. Okay, so in general, platelets are only released when they're needed. Um, from the spleen. So that's actually a nice function of the spleen. When you have a need for a lot of clotting, then the spleen can release those platelets. Um, so platelets, again, platelets are fragments of megakaryocytes, which I showed you up here. Those are the megakaryocytes. They're platelets of that, so they're fragments of that, so they have all of the cell stuff that the megakaryocyte had to begin with. Thrombopoietin, or thrombopoietin. Thrombopoietin is it's an activating factor. It's a hormone that will trigger or cause platelet production. So that's what's going to activate these megakaryocytes. It may increase the number of megakaryocytes so you can produce more platelets. Okay, so that's the name of the hormone that does that. Erythropoietin is the hormone that increases red blood cells. So this ending, or this suffix, actually kind of makes sense. All right, so where is it made? It's kind of made all over the place, thrombopoietin. When we talk about hemopoietin, that's made pretty much just by the kidney. But thrombopoietin it can be made by the liver, by the kidney, smooth muscle, and it can actually be made by the bone marrow. So you have this sort of sampling. Again, these are parts of a cell. We're going to see in the next slide where they have a lot of cellular properties, but they have signaling molecules. They're kind of letting the rest of your body know that they're there. And so when you see a decrease in the number of platelets, then you can release this hormone thrombopoietin, and that'll increase. So as it starts to fall, it's negative feedback. As it starts to fall, it can increase. And you try to keep that kind of in a constant tight range. Okay, so if we look at the platelet structure, it looks honestly just like a cell, except it doesn't have a nucleus. Okay, so there's no nucleus in there. The nucleus will remain in the megakaryocyte, but it has things. It has it has some things. It has mitochondria. It doesn't really have an endoplasmic reticulum or anything like that, or a lot of other organelles, but it does have the mitochondria, and it has a lot of these other factors. It has, in fact, if you remember from the muscle system, has actin and myosin. Okay, so we can maybe predict what's going to happen there at some point. Maybe that actin and that myosin will get together, and this platelet will constrict and actually get smaller, and that's exactly why those are in there. But it has a lot of proteins, glycogen for energy to make ATP. So it has other enzymes that are producing ATP, and it kind of keeps it going for a while. It's got microtubules to give it a structure. It's got proteins on the outside, which can help with signaling and things like that. So some of the other things it has are that are going to be important for us is fibrinogen. So it has fibrinogen, which fibrinogen can be activated to turn into fibrin, which is going to make the fibrin mesh. Okay, so once these platelets coagulate, or I'm sorry, once these platelets activate and start to adhere to each other, then this fibrin mesh can come in and kind of hold it all together along with some red blood cells, and that's going to form a plug. Okay, so fibrinogen leads to the fibrin mesh formation to form a plug, and then it also has, which kind of makes sense, it has signaling molecules, like it has thromboxane A2, which triggers more aggregation. So once you have some clotting, then you release more thromboxane, and then you end up with more clotting or more adhesion of these platelets. So that's actually a great example, a lot of times used as positive reinforcement. You have a little bit of clotting, which leads to more clotting, which leads to more clotting. That's positive reinforcement. It just increases. It also has plasminogen and plasminogen activator inhibitors. Okay, so plasminogen can be activated to plasmin, which breaks down clots. So plasminogen activators are going to activate the plasminogen, which is going to break down the clot. This may not make sense just yet. So we have to inhibit the things that activate the plasminogen. However, it is providing the plasminogen. Okay, so this might make sense if this is the second time through hearing this. Plasminogen is ultimately going to make this plasmin, and then the plasmin is going to break down the clot. Okay, so initially, and this is all part of the timing, you don't want a clot. Clots weren't made to last forever. And so you want this to break down at some point, but you don't want it to break down right away. So it kind of has these inhibitors in there that will inhibit it for a while to kind of delay that. Okay, so it can trigger aggregation, and it prevents the clot from dissolving too quickly. Okay, so it has growth factors to stimulate injury repair. So if you have clotting, that means there was damage. So it kind of makes sense that the platelet would release some of these growth factors, which then these growth factors can go on to cause proliferation of endothelial cells or something like that, fibroblasts and things like that. It has serotonin and histamine. Serotonin and histamine also can trigger adhesion. We've learned they're involved in the inflammatory process. We're not done talking about histamine anyway just yet, but we're going to talk about that in other chapters. But these are, they also include, so the inflammatory process, we've kind of touched on that, including vasoconstriction and vasodilation. Okay, so depending on what the effect is and what's needed in that certain area. Okay, so we're going to talk a lot about coagulation factors, and there are 13 of them, and it's a fairly complex process to actually get a clot to form. And so there are a lot of factors, and we have this sort of drawn here. It's broken down into an intrinsic system, and when we say intrinsic, remember this, intrinsic means that it's coming from the blood. So that's from the blood itself. These factors, these molecules that are floating around in it will be activated, and then it just sort of starts this chain reaction where one activates the next one, which activates the next one, which activates the next one. Okay, and then we also have an extrinsic system, which extrinsic in this case means it's not coming from the blood, instead it's coming from the tissue. Okay, so that means that the tissue will then release something which activates something else, which then ultimately, and you can see that where these come together, and that's really what we're most interested in. We are going to talk a little bit about factor 8 here, but where we're most interested in it is from factor 10 on, because the extrinsic and the intrinsic both will activate this factor 10, and then that will go on to turn prothrombin into thrombin. Thrombin turns the fibrinogen into the fibrin, these fibrin monomers that will then come together to form the fibrin mesh. Okay, so that's mainly where we're interested in it, and you can see there's one other thing to point out here. You can see all along the way that calcium is involved. So calcium is involved in the intrinsic, it's involved in the extrinsic, and then it's involved where they both come together and fibrinogen. So you can see that calcium is kind of a factor all the way through the system. Okay, and I have this, I don't mean to jump ahead too much, but I have this written down here, that deactivation of calcium is necessary when storing blood to prevent it from clotting. If you prevent, and you should be able to see that if you just sort of trust that all of these crazy events are going to happen, and that calcium is involved with all of them, that if you block calcium, well, you're going to really block any kind of chance of clotting. Okay, and that's absolutely true. Okay, so these guys, these 13 blood clotting factors are found in the blood. They circulate as pro-coagulation. So pro means that they aren't ready to be functional yet. They can be, but they're not there yet. So pro-coagulation factors, most are synthesized by the liver, as I said. Von Willebrand factor is made by megakaryocytes, so that means that it is produced by the megakaryocyte, and so it also is sometimes found. It's usually bound to von Willebrand factor. That's supposed to say von Willebrand. Oh, that's horrible. But anyway, it's bound to. We'll just put W. It's a lot of times found in circulation stuck to this factor 8, which keeps the factor 8 inactive. Okay, so, but mainly what we're interested in is how von Willebrand factor is made by epithelial tissues, okay, or the endothelium of the vessel, so the endothelial tissues, okay, or the endothelium of the vessel, the inside of the vessels, which are uh, epithelial tissues. I don't mean to get those mixed up, but I know a lot of people uh, have trouble with that. But that's just the inside of the vessel. So the point is that the endothelium will produce von Willebrand factor. Okay, and that's where we're most interested in it. Okay, so vitamin K, you may have heard that vitamin K is important in clotting, and it is. It is a cofactor for a number of these factors as well. Okay, so a cofactor just means that, it's kind of like you have these factors, you have the enzymes that are going to change one thing to the other or something like that. You need a cofactor. It's kind of like a car that's gassed up, ready to go, but you need a driver. So you need something that binds to this molecule and then finally activates it, and then it can be ready to go. And then once it's activated, then this factor can fall off and maybe activate something else. So that's one of the things that vitamin K does, and that's why it's important for clotting. Specifically, it's important if you don't have vitamin K, because then you will have clotting issues. You won't be able to form clots as well. Okay, so vitamin K is a cofactor for the production of coagulation factors, and warfarin or Coumadin blocks this. So it blocks that binding, blocks that process. So vitamin K is for the production of coagulation factors, and also we mention here some anticoagulation proteins as well. So vitamin K is just kind of this cofactor that's involved in clotting, but where it's most important is its role in clotting, because clotting can't take place in the first place if there isn't enough vitamin K. All right, and then of course I mentioned calcium, which is sometimes called factor 4. It's involved in many of the first steps that they actually have labeled up here, and deactivation of it is necessary if you're going to store blood. Okay, so the endothelium meaning the inner part, the inner lining of the blood vessels. That's usually so if we look at this picture down here, here are the red blood cells. So this is the inner lining this is the endothelial tissue, the inner lining of the blood vessels. Oops. And so you can see that here's this platelet. It's just sort of waiting to activate. All it needs is a stray signal from somewhere to tell it to activate. But we have these molecules like prostacyclin, which are I guess you could say reassuring the platelet. They're telling the platelet, no, it's not time to clot. No, it's not time to clot. There are other molecules that if it were to come into contact with, would activate that platelet, and those are being blocked. There's von Willebrand factor. Von Willebrand factor, if it contacts the platelet, it will cause that platelet to activate as well, and so that's not being produced. So that's being sort of either kept in the cell. This shows it being put into the tissue, but if it's released, then that can cause it. So normally the endothelium promotes blood flow by blocking platelet adhesion and activation. Okay, so we don't want that. So it can even block activated platelets. So once a platelet is activated, it can even block that from adhering to undamaged sections. So you can have an activated platelet so these are the platelets down here, the little purple things, and when they're activated, they kind of take on this star shape. actually. So you can even have an activated platelet that won't be able to bind to the wall of the endothelial tissue. Okay, or to the wall of the endothelium. All right, so inhibiting the coagulation process. That's what that's one of the things that we're talking about that the endothelium does. Membrane-bound heparin. It activates thrombin, and we'll talk more about what thrombin does. But that's also an activator of coagulation. Prostacyclin, as I mentioned, is released to prevent platelet aggregation. Um, and then something else that's produced is something called tissue plasminogen activator. Now, I just mentioned plasminogen, and I said that platelets have things that sort of stop this tissue plasminogen activator. And not to be too confusing, but plasminogen, when it is, write that here, plasminogen, when it's turned into plasmin, it will break down clots. Basically, what it does is it breaks down fibrin. So you have this fibrin mesh, and it'll just cut that to pieces, and that's going to break down the clot. Okay, so this might be released by the endothelium, and if that's released by the endothelium, then you're not going to have any kind of accidental clot formation that takes place will be broken down. Now, when the platelet is activated, it releases something that will block this process. Okay, at least temporarily, and so the clot's able to form. Okay, so the endothelium can be activated when the damage is detected, and that could be anything that shows up in here, like collagen. Collagen's supposed to be in the tissue. It's not supposed to be out here. So sometimes any kind of exposure to collagen will activate platelets, and especially when there's damage, this von Willebrand factor will be released. And the von Willebrand factor will promote platelet aggregation. So these platelets will go from these nice, more or less, they're kind of odd shaped, but they're more or less circular to sort of almost like these star-shaped things. They kind of have almost spiky. And then when they get a little bit more spiky like that, they're able to come together to form these. And I know I'm doing a mess job here. I'm not making very many stars, but you can see how they come together and they start to aggregate. Okay, so the von Willebrand factor will cause that to happen. Okay, so if we go through, if we break this down in 5 steps, which is actually kind of nice, we can kind of go through it at a little more logical or a little more directed pace. So one of the first things that happen when there's energy is vessel spasm. Okay, so this is mostly just a neural reflex. So anytime there's damage, and just like a lot of muscles, when they stretch or when they contract too quickly, they'll kind of move in the other way. So if there's damage, then in the muscular, so like in the arterioles that have muscle around them, will cause a spasm of that smooth muscle, and that smooth muscle will come together and it will constrict, and it will cause vasoconstriction. So that's kind of a neural reflex. But then when that happens, thromboxane A2 will also be released. Some of that will be released, and it'll spread that constriction to nearby areas. Okay, so it'll cause so even if you have like capillary damage or something like that, that might release thromboxane, and then that can go up to the arterioles, and it can cause constriction of the arterioles. Now usually that doesn't last very long. Okay, so if you have blood loss, it's very quickly stopped, but you don't. We learned with inflammation that stopping blood isn't necessarily a good thing. You don't necessarily want to stop blood flow to the damaged tissue, because you have to get growth factors, you have to get nutrients, you have to get oxygen, you have to fix it. And so you have initial vasoconstriction, and then usually that will go away unless it's very severe. Okay, so that's the first thing that happens, is that spasm. And then the second thing that happens is platelet plug formation. Okay, so now we have to kind of stop the bleeding as quickly as we can. And we've already mentioned von Willebrand factor is released, and we're going to focus on the von Willebrand factor that's released from the endothelium, and that's going to contact the platelets, and it's going to cause the platelets to stick together. Again, they sort of change their shape into this kind of squished down star shape, and that's one of the things. It also changes some of their surface proteins, but it causes them to stick together and to aggregate. Okay, so when that happens, the activation of them will also cause the release of some signals. One of those is thromboxane. So thromboxane then can cause other platelets to be activated, and it causes other things, other parts of the clotting process to take place. So that's platelet plug formation. I'm sorry, I just go back there because we can kind of see that taking place here. So we see the platelets start to aggregate, and that's going to, as they aggregate, they're going to sort of start trying to block that damage. But at the same time, they're also releasing thromboxane, ADP, like adenosine diphosphate, that's made from ATP. That's supposed to be in cells for the most part, but it also gets released. Okay. All right, so then we have the full coagulation process. So we made that little plug, and now we're going to have complete coagulation. And that's where these activation, or the factors that were floating around in the blood that were made primarily by the liver, now that's where these are turned on. Now remember, I said we had an intrinsic pathway that can start this process, and then we have the extrinsic pathway that can start that process. Both of these pathways ultimately lead to the activation of factor X. Okay, so factor X turns into the activated, so the A means it's activated. So the activated form of factor X, so that's activated. And once the factor X is activated, that turns prothrombin. Remember, prothrombin was kind of minding its own business, wasn't getting in the way. But once factor X is activated, it's going to turn prothrombin into thrombin. So it's going to activate thrombin. Okay? So now thrombin is going to, and this is where we form our mesh. So thrombin is activated, and that turns fibrinogen into fibrin. Okay? And fibrin, it's got a great name because it's forming kind of this fiber. Okay? So it forms this fiber that will tie all of this stuff together. It's like a web. And the platelets are in there, red blood cells get trapped in there, and it forms this well, mesh is a good word for it, mesh of platelets and blood cells, and that's going to stop blood flow. Okay, so the extrinsic pathway I have down here, the extrinsic pathway is triggered by blood clotting factors. That's not right, I still haven't fixed that. The intrinsic pathway is triggered by an endothelial tissue called tissue factor. So it's a factor made by the tissue, and it's called tissue factor. Okay, so that's pretty straightforward. But that's one of the things that will activate the oops. All right. Okay. This one is the intrinsic. Remember, intrinsic is associated with the blood. I really need to fix that. Intrinsic is associated with the blood. Okay, so that's blood. That's already floating around in the blood. The extrinsic, I corrected myself and I said it wrong. The extrinsic pathway is what releases this tissue factor, and then the tissue factor will go up to activate factor X. Okay, intrinsic, extrinsic. Okay, so once we have, so in the previous slide we had the clot that was formed. Okay, and so we've stopped bleeding, and you've also stopped the process. So the process of forming the clot is kind of self-limiting. Most of these factors only last a long time. They all rush in, and then everything starts to produce different things, and you have different molecules that start being produced that help this process move on. Now, one of the things that will happen is clot retraction. Okay, so we've had maybe some healing, maybe some connective tissue has gone in there, maybe some of this these epithelial tissues have come back together, and so you have actin and myosin. Remember, the actin and myosin that are also found in muscle are then activated, and that will cause the platelets to constrict or contract, and that will squeeze the serum from the clot. And I have down here serum. A lot of times people will talk about serum, blood serum, and they really may mean blood plasma. Serum, technically, when you use that term, and that's probably something to keep in mind, serum is blood plasma that doesn't have the clotting factors. In fact, most importantly, it doesn't have fibrinogen, and that's usually how you see it defined. It's blood plasma without fibrinogen. Okay, so that's what serum is, and usually to make serum they just put blood into a vial. That's the way we did it. We just put blood into a vial and then wait for it to clot and then pour everything else out that was left. Okay, so that's what we have: clot retraction, squeezing it, and what that does is that plasminogen that was trapped. Remember the plasminogen that the platelets had was trapped in the clot is slowly released. Okay, so plasminogen activators are slowly released, which will then slowly activate the plasminogen and turn it into plasmin. Okay, this is an important process, or it's an important concept. It's an important concept clinically. Especially when it comes to treatment. So plasminogen activators are slowly released. They turn plasminogen, and this is where it shows this here, plasminogen into plasmin. Okay? Plasmin dissolves clots. Okay? It dissolves clots by breaking down that fibrin mesh. Okay, the fibrin mesh goes away that was holding everything in place, and everything just sort of moves out and dissolves, gets recycled, whatever. So everything just kind of leaves at that point, and usually is taken up by macrophages or something like that. Now, so tissue plasminogen activator is what it's called. Tissue plasminogen activators released by the platelets as well as the endothelium. So this is the plasminogen activator we were talking about, and activates plasminogen. Okay, so it's called tissue plasminogen activator, or TPA. The reason I'm trying to kind of slow down and talk about this and make sure that you understand that plasminogen activators turning plasminogen into plasmin, which breaks down fibrin to release the clot, is because of this question right here. Do you see a use for TPA in strokes, MI or myocardial infarction, etc.? If you're trying to break down a clot, if someone has a clot, some kind of a whether it be an embolism or if it's a clot leading to like a stroke or to the heart or anywhere, if you're trying to break down the clot, one of the things, if somebody comes in with an MI, then one of the things that they would be given is TPA, tissue plasminogen activator, and they might be given something that prevents clots as well as something that breaks down the clot, and that's what it does. Okay, so I hope I've stressed that enough. TPA breaks down the clot. It doesn't just prevent them; it breaks them down. Okay. So if we start talking about some of the pathologies that are associated with, well, it makes sense. We've got this delicate little process, these clotting factors, and this process that can form a clot just on demand. And one of the problems is sometimes it does it when it's not supposed to, and we call that hypercoagulability. Okay, so that's a nice name. Hyper meaning increased or elevated. So these are going to predispose, or they're going to lead to a thrombosis. Remember, thrombo means clotting, so it's going to lead to a clot, a thrombosis. And a thrombosis can lead to blood vessel occlusion, or blocking the blood vessel. Okay, so if we have too much clotting that's happening where it's not supposed to, then that can cause blood vessel occlusion. You block the blood vessel, which we can see very graphically right here. So you can see these clots have formed in here, and that's going to very much restrict, if not stop, blood flow. So if you have a thrombus that occurs in the artery, most of the time, okay. Now what led up to that maybe it could be a number of different factors, but usually when it finally takes place, and the areas that it takes place is usually caused by turbulence, or it's in an area where there's high turbulent flow. And they don't know why. I've checked into that as well. They don't know exactly what causes the thrombus to form initially, and why it's turbulent flow that does it, but they've done very, very detailed controlled studies, and they found out that the more turbulent flow, the more clotting that takes place. The less turbulent flow, the less clotting. Okay, so we know that turbulent flow directly leads to platelet aggregation, and that's usually where we see it. And that's why this is kind of a nice little graph. You can see down here where it starts to come together. Okay, so you can see that maybe there's a little bit more turbulent flow in this area, and then you start seeing a clot form. Okay, so turbulent flow just means instead of nice, smooth flow, it's kind of messy. Okay, it's turbulent. All right, so that's arterial, and hopefully that makes sense why you would see that more in the arteries, because you have higher pressure, you have more higher velocity in the arteries than you do in the veins. So the veins are very, very low pressure. Okay, and it depends on the vein whether or not it's high velocity or not. But a lot of times in someone who's not moving around a lot, because the veins really rely on one-way valves to kind of keep blood moving. They kind of relies on you to kind of squeeze those veins a little bit, kind of massage them, and because it's so far away from the heart by that point that really the pressure can't push it through as well. So the pressure is really, really dropped in the veins. And so you kind of depend on movement of your legs to kind of use those one-way valves, and to kind of you squeeze the vein, and it pushes the blood forward, and then the blood can't get back because you've got these valves. And that's what keeps it moving. Now the problem is that in the veins, the problem is that in the veins, sometimes if you don't move, the blood tends to sit, and we call that stasis, or stopping, or not mobile. That's what stasis means. And so the blood just kind of moves slowly, or doesn't move at all. And again, I looked for this, and there aren't any real certain reasons why that happens. It's probably because you have factors on the endothelial cells that are capable of causing clotting, and you have this increased. So if we think of a platelet in there, and maybe if everything's moving along just fine, that platelet maybe gets activated, but it just keeps moving. Okay, and it doesn't interfere with anything else. It's not able to activate anything around it. However, if it gets activated, it might activate this one, which might activate a few more. And then you have sort of this clot that starts to form, because it's even though it was a very small signal, it was something very small that actually started this process, it was able to spread to other platelets that kind of slowly were moving by. Okay, so that's probably what it is. That's the best reason I could find. All right, so we say that, yes, so venous thrombi are caused by stasis, arterial thrombi are usually caused by turbulence. Okay, so platelet aggregation and fibrin complexes are caused by coagulation factors. Okay. All right. Okay, so more hypercoagulability. Two main categories of it: conditions that increase, and this kind of makes sense. Our book and our brains actually like to categorize things, and so the categories that we come up with here are conditions that increase platelet function. So we're increasing platelet function. That's a focus on the platelet, and the other one is increased coagulation system. Okay, so the coagulation system are all those factors that are floating around that cause coagulation. So those are other categories. So those are two main categories of hypercoagulability. Remember in the previous slide we were just sort of talking about, venous or arterial. So what might cause increased platelet function or adhesion of platelets? So one thing might be to increase the platelet count. Okay. So you increase the platelet count, we can call this thrombocytosis. Thrombocytosis is when the platelet count gets to above 1 million. Okay, so that's thrombocytosis. Platelet counts above 1 million, and we're talking about 1 million platelets per microliter. So yeah, somebody has to either run that through a machine or look at it on a slide and count them in a small area and then kind of extrapolate that out. But you can count the number of platelets in 1 microliter, which isn't very much. It's not very much fluid. That's a lot of platelets, though. Blood flow disturbances, so conditions that increase platelet function, blood flow disturbances. So we sort of talked about that. Turbulent flow and such. Endothelial damage. So any kind of endothelial damage, again, that's the inside of the blood vessels. So any kind of damage will activate platelet activation, okay, and adhesion, okay, which can cause a thrombus. Okay, so those are things that kind of focus on platelets. Accelerated coagulation system. So maybe you just have an increase, and this is pretty straightforward actually. What if you have an increase in the procoagulation factors in the blood? Okay, all of these factors that are being made primarily by the liver, you increase the numbers of those, and you're going to increase the odds or the chances that something is going to kind of go wrong and trigger a coagulation a little bit prematurely or when it shouldn't take place. Now the other side of that is the anticoagulation. Remember, we have procoagulation, then we have things that are saying no, 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 don't clot. And so we may have a decrease in the anticoagulation factors in the blood because these guys are kind of constantly, I don't want to say at battle with each other, but they're trying to keep your blood, make your blood only clot when it's supposed to clot. So if we kind of screw with the numbers of these, and then we're going to tip the balance in one way or the other. And in this case, we're talking about hypercoagulability. So that's the direction we're tipping that. So what may cause this? Well, it may be hypercoagulability may be inherited, and this kind of makes sense if it involves the coagulation factors. Okay, so the coagulation factors are proteins. They're made in the liver, mostly, and so maybe if someone makes too many or something like that, or maybe they make anticoagulation factors that are a little bit mutated, or it's making them wrong, or the enzyme that makes them is messed up. Something is some kind of a mutation that has been passed on is messing with this. Okay, now otherwise. And this is maybe something we'll see more often, it may be acquired. Bed rest, immobility. So we sort of talked about that. Okay, bed rest and immobility. Oral contraception use can increase it. Increased can increase the coagulation factor. So increased estrogen leads to higher coagulation factors. I mentioned if you have your spleen removed, the spleen holds a bunch of platelets. You may have a decrease in platelets or something like that. You may have a little bit harder time controlling your platelet levels. Now, a lot of times platelets, you may come in and you may see somebody that has elevated platelets, and it may not really mean any. Okay, it means something obviously. But it may not be an emergency situation. You may just have to kind of keep an eye on it to make sure their body gets them back down to normal. Okay. So one example of increased platelet function that we all kind of see, and we're kind of putting together exactly what atherosclerosis is. Atherosclerosis are the formation of these plaques, or which cause the disruption in blood flow. So we've talked a little bit about macrophages that kind of collect in here. They're trying to fight off some some damage or something, and it sort of turns into this chronic inflammatory response. And these macrophages move in, they can't clear it, they form what are called foam cells, and they start to push in on this endothelial tissue. Okay, so they start to push in on the endothelium, and when that happens, it causes a narrowing. Okay, well, high blood pressure can also cause damage in certain areas. This, as you can imagine, may cause some exposure of some of these clotting factors to the platelets that are rushing by, kind of minding their own business. But then you've got this really messed up area, and I wish I could be more specific than that. But you have this messed up area that may be releasing some of these clotting factors, which could cause some platelets to aggregate, which can cause other platelets to aggregate. And then you just sort of have this problem. You have this thrombus that's forming and this thrombus that's growing. And usually we like to see that early on. If we could see a clot that's forming, we like to see it before it just plugs up. And then you have ischemia, and if you don't get to it in time, then you have an infarction, which is where you start to get necrosis and cell damage behind it. Okay, so that's that's increased platelet function. You have this thrombus that's forming, this increase in clotting that takes place here. Okay, so bleeding disorders. Now we associate bleeding disorders with decreased platelet levels. So if you have tissue here, you have a blood vessel here, and you have any kind of damage, well, you're going to have bleeding. Okay, so bleeding is going to take place. It's going to move out of the capillaries if that's where it happened, which is oftentimes where it does happen. So the bleeding happens out here. But remember, what we want to happen is for platelets to move in and aggregate and block the blood flow. Well, if you don't have platelets, then any kind of bruise can be, well, actually you have bruising where you don't even realize you've damaged platelets. Usually these guys are fixed so quickly that you never see it. So you'll have an increase in bruising. You may see increase in bleeding in the nose and the mouth. Places where you have some of these surface capillaries that are very close to the surface that can then bleed. So small injuries happen frequently throughout the body. In the intestines, that's a place where there's sometimes damage that takes place, and they have to be plugged quickly. Okay, so when our platelet counts are less than 100,000, now we're talking about a very low platelet count, and we call that thrombocytopenia. And that is platelet counts less than 100,000. So that's where you might have a bleeding issue. Okay, that's where you might have a problem with bleeding. That's you maybe wouldn't want to if someone had thrombocytopenia, which just means that their platelet counts are low. You may not want to give them an aspirin or something like that because they will have difficulty clotting. Spontaneous bleeding can occur when they're less than 20,000. This is again 100,000 platelets per microliter. Okay, so decreased platelet function can happen in various ways, and it kind of goes back to a lot of this you don't make as many. Decreased production, increased destruction. So lots of different things can cause decreased production. We're going to talk about some of those. Increased destruction, or maybe you have damage all over the place or in a lot of areas, and they're used up forming clots. And we sort of think of the human body as just having this endless supply of things, but we've been talking about a lot of things. And so even though we have a number of platelets, it takes quite a few platelets to form a clot. And so we can reduce the number, hopefully not use them up completely, but we can reduce the number when we have like a trauma or an increase in clotting throughout the body. Okay, so we're going to talk about thrombocytopenia disorders. So thrombocytopenia, remember, thrombocytopenia means platelet count of less than 100,000. So if we have some of these This is a thrombocytopenia disorder, and it's called idiopathic, which means we don't know what causes it, or it could come from, any number of causes. Thrombocytic purpura. So idiopathic thrombocytic purpura, or ITP, sometimes you'll see people refer to the I as meaning immune. And the reason for that, and that's actually not a bad way to remember it, is because it tends to be autoimmune. Okay, so it's an autoimmune disorder which results in the formation of antibodies. Okay, remember the plasma cells make antibodies against, so the antibodies are those sort of Y-shaped things. Have to draw a perfect antibody, and I failed. So autoimmune disorder resulting in the formation of antibodies against platelets. Now, why would you do that? Why would you form antibodies against platelets? Well, clearly this is a problem that the immune system had. So it leads to excessive destruction of platelets and increased bleeding. Okay, so that makes sense. We're now labeling these poor platelets with antibodies, and so your immune system is going to say, okay, well, you've been labeled as an enemy of the body, so we're going to destroy you. While you get rid of the platelets, you're going to have increased bleeding. It's more common in children, and it's usually follows a viral infection. Okay. Well, a lot of times it resolves on its own because the virus, it may be the activation of the immune system and the activation of these B cells to produce these antibodies. This is a hypothesis, this is an idea, is that this antibody is, or the virus that it's attacking, either way, the antibody just kind of gets confused, and here's virus over here that it's attacking, and here's platelet over here, and maybe the platelet over here, and maybe the platelet, some of the proteins on the platelet look enough like the viral proteins that it will also attack that. So sometimes when the virus clears up, then you won't see this anymore. It'll just kind of go away, and the antibodies will be reduced. But it can, we know how the immune system works. It can flare up again, but you just kind of hope not, or you may never see it again ever. Okay, the other one here, so that's ITP. The other one here is TTP, or thrombocytopenia purpura. And that is a combination of thrombocytopenia. So we have low platelets, hemolytic anemia, which low platelets, if we think about, there are a number of things that are happening here. You have an increase in actually some clotting that may take place in microvascular areas. So areas with small vessels, capillaries. And when you have this widespread microvascular occlusion, then that's going to, when you see that happening in a number of places through the body, that's going to reduce your platelets when they start clotting. There's also an immune factor to this one too, but not so clearly as with the ITP. But you see this clotting that takes place. And so you have widespread microvascular occlusion. Well, then you get hemolytic anemia, because then you've got red blood cells that are trying to get past this. And I know I drew this very, very small, but you see red blood cells that are trying to get past that, and a lot of times it will break the red blood cells. And that's hemolysis, when these red blood cells that are trying to squeeze past there, maybe they burst. Okay, that's supposed to show an exploding red blood cell. So then you end up with hemolytic anemia associated with it. You've already got microvascular occlusion, which may increase at that point, because now you may have some necrosis, you may have some damage, fever, neurological abnormalities. it could be an abrupt onset, and it can be fatal, and it can move kind of quickly. And so one of the things that you want to do is do a transfusion. Okay, so you want to get rid of the blood that's causing the problem, and you want to bring in new blood. And so without that, yeah, the it can be fatal. I don't want to quote it because I'm not sure, but it's somewhere in my head I'm thinking 80 to 90% without any kind of treatment. But don't quote me on that. Okay, don't write it down. I'm going to delete this after I finish it. Okay, so multiple etiologies. Inciting event is endothelial damage and activation of intravascular thrombosis. So what does that mean? Endothelial damage, that's the inside of your blood vessels, obviously, and activation of intravascular thrombosis. So that means that you have lots of damage all over the place that can cause platelet aggregation, which then can cause decrease, and that's where it's kind of this is actually kind of a common phenomenon where you have this increase in the um, activation of intravascular thrombosis, and that's going to decrease your number of platelets, which can then lead to this kind of a symptom, which is you're not able to form clots anymore. Okay, so you're not able to form clots. Your platelet levels drop because there's too much coagulation, and all the problems that causes. And so you also see this kind of a symptom where you have sort of bleeding through with any kind of problem. Okay, so one other thing to talk about with impaired platelet function, I kind of mentioned this earlier. I said if you have problems with clotting, where you're not clotting well enough, then you may want to stay away from aspirin or NSAIDs. You may not want to give a patient aspirin or NSAIDs if they have a problem with clotting, because unless it's hyper, you don't want to do it if they're not able to form clots. Okay, so I say we remember this. I always say that. I don't actually think that you remember it. I hope that you do. But from previous section where these phospholipids up here, we talked about the omega-6s and the omega-3s. These phospholipids up here, the little tails on them, can just sort of be rearranged, bent around like a paperclip, like you'd bend a paperclip, form something called arachidonic acid, and then that turns into these things that we keep talking about, prostaglandins. And now we're talking about, we've already mentioned the word prostacyclin, and I'm going to erase that and circle it really bigly here, and that is thromboxane. Okay, so thromboxane is, remember, that was something that was triggering the coagulation process. Okay, so go back and look at that. Thromboxane is involved with triggering coagulation. And so if you think about what aspirin and NSAIDs, nonsteroidal anti-inflammatories like ibuprofen, are doing, they're blocking the cyclooxygenase pathway. They're blocking this COX enzyme. And so you don't get as much MAID. You don't get that we think of treating pain, inflammation, fever as blocking the prostaglandin. Okay, that's fine. Okay, that's what we want to do. Maybe we want to block pain and inflammation. But it also can block prostacyclin and can block thromboxane. Okay, so that's why it's sort of a clot preventer. Okay, that's why a lot of times people who may be at risk for stroke or a heart attack or something, they have like half an aspirin or something a day. Aspirin binds irreversibly to the cyclooxygenase. Okay, so it blocks it for as long as that platelet is around. The lifespan of the platelet, 8 to 10 days. That means you take an aspirin and it will block the cyclooxygenase pathway. And when I say block, it doesn't necessarily block it so it can't happen anywhere in the body, but it reduces it. Okay, so it blocks it, and then you don't want to block all of it. That would be too much. So it it binds irreversibly, so it comes down, it sits on there, and it just says, okay, your job is done, and it reduces that until the platelet dies and a new platelet comes in and replaces it. NSAIDs, however, will bind to it and say, okay, you stop for now, and then after it wears off in a few hours, it goes away, and the cyclooxygenase pathway starts to work again. Okay, so that's the big difference between those. Okay, and that's why, we talk about aspirin. You give an aspirin, it's a little more of a chronic treatment. You just kind of keep it. You have one every day. You make new platelets, and you kind of keep their clotting ability down. Okay, so other coagulation disorders. So this is disorder with forming the clot, coagulation. Remember von Willebrand factor. It causes platelet adhesion. Von Willebrand factor causes platelet adhesion. Well, they're the most common hereditary bleeding disorder where you can't have platelet adhesion is a mutation or a defect in your von Willebrand factor. If you have a deficiency or a defect in your von Willebrand factor and its job is to cause platelet adhesion, then you're going to have reduced platelet adhesion. You're going to have reduced clotting. Okay, so that's why it's a bleeding disorder. Okay, so I hope that makes sense. Now, so we just said platelet adhesion, but the thing is, I think I mentioned that von Willebrand factor also carries this factor 8. And so factor 8 is involved in other parts of the clotting process. And so because von Willebrand factor is associated or carries factor 8, then you also have defective clot formation, and so it gets tied together. And the symptoms are things that make sense for a symptom of a bleeding disorder: bruising, excessive menstrual flow, spontaneous from the nose, the mouth, GI tract. Okay, hemophilia. May have heard of hemophilia. It's an X-linked recessive disorder in males. So it's X-linked. So if you're female, you have 2 X chromosomes. If you're a male, you have an X and a Y. Well, it's X-linked. So that means that dad, if you're mom, okay, so if you're a mom, you may have one that's defective. Okay. And it doesn't make this factor 8. Remember, the factor 8 that's involved in clotting doesn't make it right. So if you're a mom and you have a kid, well, you've got about a 50-50 chance of giving either let's say you give the hemophilia. Well, if you're the dad and let's say you have it, well, you're definitely giving it. Okay? So that means that this person right here is making 2 defective factor 8s. This person is going to express it. Well, let's say you're the mom and you give the factor, you give an X, but this time you give this X, you give the healthy one, and then you have a, let's see, you have a son's going to be healthy if you're the mom, and you have the X, it's going to be expressed. Okay. I guess I'm another way to look at this is, what if dad's completely healthy? Dad's completely healthy, so if he has a daughter, then the daughter's going to be okay because it's recessive, which means that, guess what? Dad's X is going to make a perfectly functional factor 8. Daughter's going to be fine. Okay. However, if you have a son gets it. He doesn't have any backup. He doesn't have a backup plan. He's not going to make a factor X, or he's not going to make the factor 8. Okay, I don't want to get into a big genetics explanation. I feel like I tried to dip my toe in it, and it kind of got out of control because now I want to draw entire Punnett squares. But hopefully you've been over that concept enough that you kind of understand it. I'm not going to ask you to draw a Punnett square or do the math But that's what X-linked means, that if you're a male, you're more likely to express it because you've got a 50-50 chance from mom of getting a bad copy or a good copy. If you're a female, you've got two X's. So if you do get a bad one, you've got a backup. Boys don't have a backup. All right, so that's my main point there. Okay, so faulty factor 8. I don't know what I was calling it. Faulty factor 8, which is an important part of the intrinsic pathway. And so you're not going to be good at forming clots. That process isn't going to take place very well. So the severity of the bleeding depends on how much normal factor 8 is produced. Okay, so that means that if you have that backup copy, and that tends to be the case for females more often. If you have that backup copy, you should be okay. But a female, a female would have to get it from mom and from dad, which is much less likely to happen. Okay. So manifestations, bleeding in soft tissue. Now the manifestations of this can cause a lot of the problems with hemophilia. Bleeding in soft tissue, GI tract, and joints, and that can really cause a lot of problems. So here you already have a bleeding disorder, and now you have joint pain and swelling, and it can make things like surgery very, very difficult because you may not be able to recover from it. You might be able to do a transfusion or something like that, but it can be very much more risky than for a person who has a healthy clotting system. Okay, so one more thing, which is similar to something we've already talked about. This is called disseminated intravascular coagulation. Okay, so what does that mean? Disseminated means it's spread all around. Intravascular means it's inside the vessels, and we're talking about coagulation, so clotting. So caused by, so this should just sort of make sense, caused by massive activation, disseminated, activation of coagulation due to production of thrombin and the formation of fibrin. Okay, so we're getting clotting that's going along. It's massive, it's disseminated, it's happening in lots and lots of places. And what do you think that's going to do? It's going to pretty much run you out of clotting factors. It's going to run you out of platelets. So widespread intravascular coagulation and bleeding. Okay, so you have coagulation and you have bleeding because you've pretty much taken all the coagulation you can get. So high clot formation consumes available coagulation proteins, that's what I was just saying, and platelets, leading to severe hemorrhage. Okay? So small vessel occlusion can cause ischemia and organ failure. This is not necessarily immune related. So we see a lot of the same symptoms as we saw with TTP: petechia, purpura, oozing from puncture sites, severe hemorrhage. Because it's a very similar disorder. It tends to be a secondary disorder. A secondary disorder that occurs as a complication of many other disorders like trauma, postpartum bleeding, cancer, liver disease, etc. And it can move very fast. So it's something that you want to get a hold of very quickly. And here we see the petechia and the purpura. Purpura is just a bit larger, but it's still just, you don't have the clotting capabilities, so blood tends to move out into that area. Okay, well that's the last slide for this section.